So good afternoon, everybody, and as you can see, this session is very unimaginatively titled Slide Seminar because I couldn't think of any clever things to say about what I was going to do here. If you see the subsequent topics and the big guns who are going to speak after me, they have very nice and interesting sounding names. What I've tried to do is put together cases, try to link them in a way, cases that were interesting and taught me things. I hope you enjoy listening to them. I would like to be told when I'm at around 20 minutes of the talk so that, I know how much time. Thank you. 18-year-old girl presented with acute abdominal pain. Her ultrasound showed a twisted ovarian cyst, 4 centimeters in size. And what was received were multiple pieces of a flat cyst wall. These were the sections that we received. You can see a flat cyst wall here. There is evidence of fresh hemorrhage which happens secondary to torsion. And again, evidence of hemorrhage. We can see some solid areas over here. I'm sorry, is there a... So what you see here is very obvious, isn't it? It's a corpus luteal cyst, and I thought it was a corpus luteal cyst which had undergone torsion, and that's what I was going to sign it out. This came at in the last batch of cases that we get in the evening, and I wrote out my report, and then somehow I didn't want to wait. I said, okay, I will sign this out when I come tomorrow morning. So I came in the next morning and like we do for cases that we've left the previous day, took a look at it again. And to my horror and thanks to my guardian angels, I found that I had missed this the previous evening when I was looking at this case. And we can see foci of a tumor. You can appreciate it. There is a vague reticular pattern. These are so we can see these large atypical cells, some of them with clear cytoplasm, pleomorphic nuclei which are lining these spaces and somewhere scattered within the stroma. These were almost inconspicuous. If you saw this case in a hurry, like I did the previous evening and missed it. And here is another clue. Here are the hyaline globules that were seen. So put up the immunohistochemistry. These cells express SAL4. There was expression of AFP and glypican-3. So what I would have missed that day in my hurry to go home was a yolk sac tumor of the ovary which had very tiny foci in the cyst wall. So this is just a cautionary thing for myself not to be in a hurry, and maybe for the younger people in the audience that take enough time on every case that you put your signature on. The next case is a biopsy of a sacral lytic lesion. This came from a 60-year-old man, and we got a biopsy, and this is how it looked. We can see sheets of cells. Perhaps there are few cells which look a little larger over here. And on a higher magnification, these are ovoid cells. They're again in sheets. I don't know if you can see the details from there. What is noticeable is also the sprinkling of lymphocytes that is seen throughout over here. Again, some slightly larger cells. Here I would like you to appreciate that these cells have this nice nuclear membrane, very neatly as if drawn by pencil, and there is this single conspicuous nucleolus that one is seeing. It is appreciated everywhere, again these small lymphocytes. So there's really only one diagnosis over here. The site is a little unusual, it is in the bone. So would anyone want to venture what this is? Okay, so we call and we ask for history, whether there was any previous surgery done while we did immunohistochemistry, and this is CD21, CD35 and CD23. So what we were looking at was a follicular dendritic cell sarcoma, and we got a history that 2 years ago this patient had had resection of his parapharyngeal mass and had now presented with this lytic lesion in his sacrum. So this is what it was signed out as. And there is a paper from our lab about extranodal follicular dendritic cell sarcomas, which are considered intermediate grade malignancies. And although it comes under the histiocytic and dendritic cell neoplasm category of WHO, these extranodal ones behave more like a soft tissue tumor, and they're treated like that, typically with resection, with or without chemotherapy. And what I showed you was a very classic morphology of these FDC sarcomas. And another important clue is almost absent or plasma cells, and multinucleate tumor cells may be seen. Local recurrence and distal metastasis can occur, but sometimes the gap is several years. An interesting thing about these is that the lymphocytes that we see scattered within the tumor are sometimes TDT expressing T lymphocytes, which are responsible for something called the paraneoplastic pemphigus syndrome. And many times it is this syndrome, when it is refractory to treatment, that can kill the patient rather than the FDC sarcoma. The third case was a biopsy from an 82-year-old woman. She presented with some kind of discomfort in her retromolar area, which was biopsied, and we received biopsy tissue. This is what we saw. This is the nice lining stratified squamous epithelium, and beneath it is a tumor. So even at this magnification, you can see that it is forming glands. It is composed of large epithelial cells showing nuclear pleomorphism. So obviously, like we are taught to think that does this belong here or has it come from somewhere else? In this side, the primary thing one would expect is a squamous carcinoma, but this does not look like a squamous carcinoma. So, and as you are aware, right now we are in an age where even if there is a fibroadenoma that is being suspected on clinical examination, the patient is sent for PET CT upfront because you know, it's like the modality of choice. Everyone has to undergo a PET CT. So we've called and we asked that has any scan been done for this patient. And while we waited, we did some markers. So here again, so what are the possibilities? One is that perhaps it is of some minor salivary gland origin, an adenocarcinoma, or again, it has come from some other site. So this was the PET CT information we got. They said it's a primary renal malignant neoplasm with skeletal, lymph nodal and pulmonary mets. And this was our IHC. This is CK7. Because they said renal, we did a PAX8 which was negative, CK20 was negative. Because there were lesions in the lung, we did TTF1 and napsin, both of which were positive. And this was a metastatic adenocarcinoma consistent with a lung primary. This is just to tell you about unusual metastatic sites which one must always bear in mind. Like that FDC sarcoma, you know, you don't usually see it in a bone, etc. So now to continue the series of potential metastatic sites, this woman was being evaluated. She was 65 and she was being evaluated for a lung tumor. And she was, the oncologist noticed that she had unhealthy looking polypoid nasal mucosa. So initially a lung biopsy was done which came to us, and that was a standard lung carcinoma TTF1 expressing. But the oncologist was still not happy with this nasal mucosa bit, and that was biopsy. And this is what we saw. You can see, one can see why it looked polypoid. It is polypoid, it's lined by this respiratory epithelium, and it seems to be distended with something. You know, there are these spaces which appear pink, and there's something which, here, this is a better view. One can see these large cells which seem to be stuffed into lumina, and these appear to be capillary lumina. There is bone which was seen over here. Looking at these cells, large cells, round nucleus, it doesn't really look like a lung adenocarcinoma. So whether it was a lung carcinoma or is it something else? Any thoughts from people who are sitting behind? Okay, so it didn't look like a carcinoma. What it did look like was a lymphoma, and it's a very, see, everything is limited to these spaces. There is evidence of hemorrhage. There are places where, you know, these fibrin thrombi could be seen. Again, large cells in capillary walls, fibrin thrombi, and this was the immunohistochemistry. So there was CD45, CD20, MUM1 and MIB1. So it is a B-cell lymphoma, but it is a very specific type of a large B-cell lymphoma. It is an intravascular large B-cell lymphoma, and this we call as a non-GC subtype. Now, what is special about this lymphoma? It is that it usually is found in capillary lumina. It typically spares veins and arteries, and probably thought to be because of a defect in the homing mechanism of these tumor cells. Two classic there is a classic Western type which is neurological or cutaneous, and there is a hemophagocytic syndrome associated type which is seen more in the Asians. And the interesting part is that this can be diagnosed even with a random skin biopsy. There may be no skin lesion evident, but if a biopsy is just taken, one might find this lymphoma sitting below in the skin. And it is generally an aggressive lymphoma, and it has a tendency to relapse in the CNS, which is otherwise considered to be an immune protected site. So this again, so here's the question, like sometimes oncologists, the treating oncologists feel that when they see disseminated disease, they feel that do we have to biopsy multiple sites? Now that's not an easy question to answer, because sometimes you may just have the same tumor sitting at different sites. Sometimes it may be tuberculosis, or sometimes it might be a completely different pathology. So there's no easy answer, but maybe something which looks unusual, which is beyond what is expected with that primary tumor, needs to be biopsied. So we are speaking of nasal mucosa. So I moved to a case of a 47-year-old man who had a maxillary sinus mass which extended to his nasal cavity. Again, tissue lined by respiratory epithelium. This is all minor salivary gland. I don't have a higher magnification of this. And this is the area of interest. One can see a very blue looking tumor. And this is what it is. It looks very high grade. There are areas of necrosis. And it has a very basaloid look, very irregular kind of cell nest. Not exactly jigsaw puzzle, but again a very high grade looking tumor. And here some degree of palisading, brisk mitotic activity, a high NC ratio. So one thinks that okay, this is a carcinoma, and those of you who are familiar with the classification of sinonasal tumors, you know that it gets more and more difficult, because it's not always very easy to classify them without doing extensive IFC. So one can say that this is some kind of a high grade carcinoma. What kind of carcinoma will have to be worked up. And interestingly, there were these foci of what is called abrupt keratinization. That is when you have a very high grade looking tumor and suddenly these foci of keratinization pop up. So when I show you abrupt keratinization, again those of you who are familiar would expect that maybe I am showing you a nut midline carcinoma. So this was the panel done. It was negative for NUT, it was negative for synaptoneuroendocrine, S100 protein, CD117 EBERS, MYD, and the expression was of CK, P63 and P16. So the differentials here were a neuroendocrine tumor which we ruled out. The other differential was the nut midline carcinoma, which was ruled out. You all must have heard of this entity which was previously called HPV associated adenoid sinonasal carcinoma with adenoid cystic-like features, which is now called the HPV associated polyphenotypic sinonasal carcinoma. So that is an important differential that we need to consider here, because even that can show abrupt keratinization and it can show basaloid areas. And why does it matter? Does it matter to say whether it is a nut midline carcinoma or a basaloid squamous carcinoma or that adenoid cystic-like carcinoma? It does matter, because a nut midline carcinoma is very aggressive. A squamous carcinoma is again reasonably aggressive with metastasis. But if this was a adenoid cystic like HPV related carcinoma, that surprisingly has a more indolent behavior. It does not metastasize easily and behaves better. So with this marker profile, we call it a basaloid squamous carcinoma, and please investigate for HPV association. Just because it is P16 positive on immunohistochemistry does not necessarily make it HPV associated. So from the maxillary sinus to the ethmoid sinus, 75-year-old. Again, pieces of a tumor, almost looks like what I showed you before. Again, a blue basaloid looking tumor, fragments of bone. This part looks a little more solid compared to here. Here some kind of spaces seem to appear, maybe cribriform, and one wonders whether there is some glandular pattern. And when you see here, this looks like a edematous papilla. Again, a basaloid look with a high NC ratio. There is scanty amount of pale eosinophilic cytoplasm, and some kind of cords. A very weird pattern, and one wonders what kind of a carcinoma. Again, I'm sure you can say that this is a carcinoma and it appears high grade, but what kind of a carcinoma is it? Here, the brisk mitotic activity. I could not see any evidence of squamous differentiation over here. And in some of the cells, I think you can appreciate it, there seems to be a little more cytoplasm, which is looking a little dense eosinophilic. See over here it's kind of pushing the nucleus to the periphery. A little bit of that rhabdoid kind of appearance seems to be there at places. So these were our markers. Actually, I started with the CK7, CK20, but both were negative. And there was a P40 synaptochromo. There was focal synaptochromo. There was this really nice P40. And because the 7 and 20 were negative, we did a CK and a EMA. Both of them showed diffuse positivity. So this is what I was looking at, and it looked weird. So again, I'm stuck. Is it squamous? Is it neuroendocrine? And they can be quite frustrating at times, these tumors. So then thought what further needs to be done, and did a INI1. And this is a loss of INI1 in this tumor. This is the internal control in the blood vessels, which is positive. The tumor cells have completely lost expression of INI1. So what this was is INI1 deficient sinonasal carcinoma. I'll come back to this case a little later after case number 7, which is a 66-year-old woman who presented with a mass lesion in the pelvis. Now this lesion was completely surrounding the uterus and there was extensive local disease. What we got was a core biopsy of the pelvic mass. Again, a tumor with what looks like areas of necrosis. Blue looking tumor, trabeculae, cords. There is, yeah. So again, there are round nuclei, there is scanty to moderate amount of eosinophilic cytoplasm, ill-defined cytoplasmic borders. One can just say that it is a high-grade tumor, again perhaps a carcinoma rather than anything else. Here again some pink cytoplasm is seen here and there. Nothing to actually tell you what this might turn out to be. Some kind of attempted gland formation. So started because it was in the uterus. So Paxate, CK7, CK20, dead negative. Then so went to CK and EMA, both very beautifully positive, again telling us that it is a carcinoma. And then because it had that small cell look, a synaptophysin, which was again diffusely and strongly positive. However, the chromogranin was negative. We did NKX 2.2. We did the CDX2 was actually done in parallel after the Paxate came negative. We did a CDX2, we did a GATA3, thinking whether it is some funny large metastasis coming from the stomach or somewhere to the ovary. But CDX2 was negative. This is how the GATA3 was. Some cells here and there. So again, a tumor with just synapto CK-EMA, so okay, a neuroendocrine tumor, a high-grade neuroendocrine tumor. But because we've been reading literature, so this is high-grade. Again, we're seeing the MIB1. It is almost 95%. So again, like I showed you the INI1, so we thought very clever, let's put INI1 on this one too, but this is INI1 retained. And then we put the other marker, which is the BRIG1, and here you can see that the BRIG1 is lost in this tumor, and the internal control, complete loss of BRIG1 expression. So this one was a BRIG1 deficient small cell carcinoma. She is older than the standard definition of a small cell carcinoma of the hypercalcemic type, and we don't have information on that. So now to tell you about these BRIG1 and INI1 associated tumors. So these are tumor suppressor genes, and these tumors are associated when one of these gets inactivated. And these terms indicate the subfamily and the members of that subfamily. So the loss of BRIG1 and INI1 is mutually exclusive. And what should suggest to you that you need to look for INI1 or BRIG1? The biggest thing is rhabdoid morphology, but all tumors may not have this rhabdoid morphology. And if something looks poorly differentiated and basiloid, and according to me, if it doesn't give you very clear-cut immunohistochemical findings, there is some kind of overlap, or you're not feeling very certain of what this is, those would be good cases to test INI1 and BRIG1 on. So this is a list which is available everywhere about, so INI1s, the loss may not be complete. There may be a complete loss, there may be a mosaic expression and a reduced expression. So the case that I showed you, the sinonasal basiloid carcinoma, that is in the complete loss group, which we saw in the previous case. So this list is increasing day by day as more and more tumors are tested for this. And the sinonasal carcinomas with INI1 deficiency were described by Bishop and Agemi, and they present at a high stage. And if you notice, 56% died of disease in the first 5 years. That's why it is important to know, and typical location is the ethmoid or the paranasal sinuses. Now, this is an algorithm that I find very useful. This is based on Dr. Justin Bishop's paper on approach to small round cell tumors of the sinonasal region. And he recommends a panel approach where up front we put CK, CD99, Desmin, P40, synaptophysin, and then go down this algorithm. And if you see in his algorithm, actually the INI1 is right on top. It is after CK. So if something is cytokeratin positive, the first step he would do in addition to his panel is a INI1. So you can access this easily online, and it is a very, very good algorithm to use. The BRIG1 deficient tumors, again, there is a list which also includes some sinonasal carcinomas, the thoracic sarcomas, and here this paper I would like, no, I will show you another one. This one is from our lab, Jai and Dr. Borges wrote it. So here you can see that this is a tumor, it's a well differentiated adenocarcinoma that we are seeing of the endometrium with these dedifferentiated areas. And the BRIG1 is lost in the dedifferentiated areas while it is still being retained in the well differentiated one. So this is well documented in literature, and it is very interesting to see when one has a case like this. So does it matter, all this, labeling things, INI1, BRIG1, how does it matter, and do people really care? So right now it may not matter, maybe treatments are not being tailored as per these diagnoses, but these are all the potential therapies that are available, which include some inhibitors and then this tazemetostat, and unless we identify them and classify them, we will not be able to gather enough data to see what really works in these patients. And this is my last case, which is a 50-year-old woman who's left, sorry?
5 minutes.
5 minutes. whose left ovarian mass was excised, and this was a large mass, 20 into 16 into 11 centimeter, with solid and cystic areas. At this magnification we can see tumor. Obviously it looks like a carcinoma, perhaps with these gland formations, some papillary structures, and irregular glands with irregular lumina filled with some kind of a material. At places they are crowded. The lining appears very stratified. There are these kind of papillary structures, and the cells are columnar. They are tall, columnar in nature. Again, some areas with cribriform pattern. The stroma appears fibroblastic, nothing very spectacular about the stroma, and this was an interesting feature. So there were areas where amidst these other epithelial cells, we saw these other kind of cells which were smaller, cuboidal, and very monomorphic, regular looking, with a round nucleus, pale cytoplasm, very bland, and they were suddenly popping out in nodules. Some more images, and here is that look of subnuclear vacuolation, which suggests an endometrium kind of appearance, some cribriform areas. We did not find any teratomatous components. This is again subnuclear vacuolation. There were a lot of areas of necrosis, and this case came for a second opinion, and to give the pathologist credit, she had taken almost 45 sections of a 20 centimeter tumor. But this is how the viable areas looked. There were some areas which were like this, full of foamy macrophages, some containing hemosiderin, some cholesterol clefts. We couldn't see very, we didn't see the endometrial stroma and glands to say that, but these were features which suggested that maybe there was endometriosis too. This was the IHC again. These were negative. So one thought on morphology was, so I showed you the cells which with the endometrioid or the pseudo-endometrioid look with the subnuclear vacuolations. Now that doesn't just happen in endometrial carcinomas or tumors. It can happen in sex cord stromal tumors. It can happen in yolk sac tumors. So this was the initial thing, PAX8 negative, CK7, CK20, SF1, everything negative. So a CK, yes, it is cytokeratin positive. And then the thinking that in an ovary, if it is not primary, always look whether it is metastatic or a primary ovarian tumor. So the most likely candidate would be the gastrointestinal tract, so CDX2, which really lit up all this. But then there was no CK7, no CK20, and the morphology was not really what you expect out of a colorectal or a gastric carcinoma. So we were still not happy with just saying that maybe this is a metastasis of a GI primary. So some more markers we did. A SAL4, you can see SAL4 is lighting up all those cells. The cuboidal cells that I showed you marked with HSA, and the same cells expressing the CDX2 were expressing SAL4, they were expressing glypican-3. All the cuboidal cells did not show HSA expression. There were some which marked with synaptophysin as well. So and we really searched, we did multiple sections, we did IHC on multiple blocks to see if we could identify a clear-cut endometrial carcinoma component, but we couldn't find it. We spent a lot of time on this case, and then we phoned and asked that can we have the serum AFP levels, because we got glypican, we got SAL4. So about 3 or 4 weeks after the surgery, this was her serum alpha protein levels, 10,800, quite elevated. So eventually this is what we called it, a yolk sac tumor with extensive endodermal somatic differentiation, predominantly intestinal and focal hepatoid. And in view of the age, now yolk sac tumors are more common in younger women. She is 50. So we said in view of the age of the patient and foci suggestive of endometriosis, it is likely that this tumor is associated with an endometrioid adenocarcinoma of the ovary, which unfortunately we were not able to document in the material that we received, and it was extensively sampled. So the last I heard is that they were considering treating her as an endometrioid type of adenocarcinoma rather than a yolk sac tumor, but they were going to discuss it in the MDT. I don't have any further follow-up on this patient. And yolk sac tumors, yeah, we just have to be aware, because sometimes the somatic differentiation can be so extensive that we may miss the diagnosis of it being a yolk sac tumor and wrongly call it a metastatic carcinoma of intestinal origin. And when it coexists with the endometrial cancer, it has a worse prognosis than if it was a YST alone. So thank you.